first baseball game I ever went to was Mets against the Dodgers. And my father we went to the Diamond Club, which is fancy. I never went to a game in my life where I had the best seats. The only time I was 6 years old, and from then on, I had the worst seats in the house. I don't know what that was. So he must have known someone who had, we literally had like a meal. It's like what you do when you go. Never, we ever did that, and nor have I ever done that. This is the first time. It was, everything was down from there.
Well, now it's just so expensive.
Oh no, forget it. I'm sure. But I'm talking about even during childhood. I mean, he would go to unfortunately he died at a young age, we would go to these games, and he was in the last row of the stadium. And I would go down to the bottom, and that's what we would do it. We'd spend $1 or whatever we would spend. But that's the associate, that's the LA thing. Why am I having so true? Is because that first game. See, that's the psychoanalytic take on it.
And you probably didn't know how good you had it at 6 years old.
I had no
right?
idea.
No idea.
I know, except I do know that behavior is very hard to predict because it's so situational. Right, so I was not particularly polite, and there was a Met announcer, a guy named Lindsey Nelson, and he was one of the first 3 Met announcers, and 3 people for 17 years. And I didn't really, I started following the following year, was maybe 7 or 8, but I didn't know anyone. And then he was in this Diamond Club, and we went up to him, and I asked him, Mr. Nelson, can I please have your autograph? I never spoke that way to anybody. I just got lucky, I was actually polite for a second, and he was very impressed with that. So that's the law of primacy, remember first back. Okay, so we're talking about, we're gonna talk about now, we'll call it chapter 5 continued. And we have trauma-related disorders. If we're going to talk about this, even an exam, unfortunately, can be traumatic. When you take, bar exams, things like that, any exam for that matter. There were people, I knew someone who failed the bar exam like 10 times. He was having nightmares about the bar exam. You wouldn't think the original definition of trauma was it's a life-threatening experience. Well, not necessarily. Life-altering, but not necessarily life or death. About this test. I'm trying to take it down a notch because we know from Ricky Dotson in psychology that if you have a mild to moderate degree of emotional arousal, you do better. Right? So we want to keep that level of emotional arousal to the point where you're optimizing performance. I told you in graduate school we had a guy who, did I tell you that he studied aggression? His name was a real service.
Was this the cattle prod guy?
Cattle prod,
Yeah.
right. So you took it, you're taking your test, you're hoping not to get a cattle prod. I think that's not a good testing environment. So, I was looking up to see if there's an obituary, if he's dead yesterday. He's still alive, he's doing very well,
A lot of research on the people you talk
Yeah.
about.
Yeah.
I can see through a lot of research. I'm not good with a computer, but I can check out
Oh, no.
obituary. I can look at the obituary, actually.
You know your way around an
I do.
obituary.
The sad thing is when you come upon someone you're not expecting, and I've had a few of those. I wasn't even looking for an obituary, and how such is that doing, and then you find it, and that's the people you want to be dead are not still. Sometimes it works. Anyway, acute stress disorder. Within what period of time? 6 days.
3 days. No,
30 days.
Less than a month.
Less than 30 days. Could be immediate. Usually a singular event. Usually more something like a car accident or something that's not ongoing. Nightmares may be symptomatic of this. That's according to trauma symptoms, nightmare, feeling on edge, hypervigilant, which is sort of always on edge or feeling ready to escape if you need to. Ironically and paradoxically, numbness is also a characteristic. So you may feel very sort of shaky or very sort of hyper-reactive, but also numbness could be part of it, just not feeling much of anything.
Is that because, sorry, go ahead.
No, I was just gonna ask, you said that is 30 days?
Yeah, with acute stress,
Okay.
within 30 days. Now, don't ask me that, I have to check this out, if you're symptomatic, then it continues, is it PTSD, then I have to look at the.
I thought it was,
I think
yeah,
you
I thought it
said,
was
like-
after a month. If it continues after a month, then it becomes
It might
PTSD,
be.
is what it said in the
Oh, did you say that? Okay.
AI.
Oh, really?
I looked it up, yeah.
Okay.
Like the
please.
definitions.
Yeah, can we trust AI? I guess we.
I mean, I guess, cause I looked up a
That
few
sounds
different
right.
ones.
What about fact checker over
It's just,
here?
Well, we can.
Oh, I never trust AI.
Almost.
No,
It's like
but like.
horrible.
Yeah.
No, yeah,
No.
because it's pulling not just from like correct sources, but also from like some random nut job on the corner of the internet. You don't wanna trust that.
Oh, you don't, okay.
Do you wanna fact check it?
Yeah,
I
that's-
don't
that's
know,
a
dude,
job,
it's fine.
yeah.
It's just, this,
Yeah, I think
I
that
did
may
look
be
it
the
up
right
in the
answer
definition.
actually for that.
Yeah.
But I wouldn't frame it that way on the exam, I don't remember what I asked, but I would frame it within 30 days acute stress, 30 days or more post-traumatic stress.
Right, okay.
And then you have post-traumatic stress is 30 days plus. And then you have post-traumatic PTSD, delayed onset, I think it's 6 months or more. So you have, that's the one people often associate with war, things that are not immediate, are much more of a delayed response to a usually ongoing trauma, life-threatening, typically doesn't have to be, but often is.
So you're saying that when you're saying delayed onset, like that doesn't happen right away, that could happen
Yeah,
much later? Okay.
typically around 6 months.
that'll be delayed, a minimum of 6 months, either longer than that, could be 10 years later. It could be someone having nightmares 20 years after a trauma. You know, the pre-morbid personality, the person, what they're like, matters in terms of that. You know, you might have someone who's, you know, just very sensitive and it's just too much to bear initially, and then there is some, you know, time has passed and then they start to become symptomatic, but maybe a long time after the fact. By the way, we skipped over one in terms of anxiety, the unspecified anxiety disorder. Maybe throw that in too. If it doesn't fall into a category neatly, it's called unspecified, whatever it may be, anxiety, any of the other categories we're gonna talk about. Okay, so PTSD, delayed onset, 6 months or more. Then we have one more category with obsessive compulsive disorders. And actually, they used to have this under anxiety, so they've broken it down. They've now obviously distinguished it, and there's a distinction between, I think we talked about, what, 2 of these? No, well, the third one, OCPD, actually is not part of this. I just brought it into the equation, just to sort of mention it, but it's actually technically a personality disorder, not under this grouping. So we have obsessive compulsive disorder. Obsessive, I'm being obsessive about this. Obsessive compulsive disorder. Do you need to have both obsessions and compulsions?
No.
One or the other. Which one is the thought?
Obsession.
Behavior, obviously, compulsion. Ritualistic behavior. This is often, you know, doing the same thing, you know, same number of times. That would be an example of something ritualistic. So you often do have both, but it doesn't require it to meet the diagnostic criteria for OCD. This is the famed OCD. This can be severe or can be mild. There's a whole continuum here in terms of the OCD. Again, if anything is severe, the treatment involves a combination of talk therapy and medication. OCD would be an example of that, or panic disorder with agoraphobia. And then we talked about hoarding disorder. I don't think I asked you a question about treatment. Here, depends in terms of treatment. Certainly, cognitive behavioral therapy. I don't know if you use meds or not on this, or if there's really any efficacy of medication. I would not ask that question.
But what does the treatment depend on?
In terms of what, hoarding?
No, but you said that for treatment it depends.
It depends, yes. If it's milder for almost anything we're gonna talk about, just talk therapy. If it's more severe, talk therapy and medication. The purpose of this exam, not gonna be too much on it, but just, you should know that. Hoarding would be excessive acquisition without discardment. We then talked about some other characteristics of hoarders. It tends to get worse with time. Many times it's not treated until someone has already been symptomatic for a long time. Lack of insight. Obviously difficulty with discardment. Also the pleasure associated with acquisition is a pretty big factor. Because you're getting that neurobiological response along with that, the psychological response. So it's hard to break that ladder. Actually, we did talk about body dysmorphia too. I'll throw that in as a third one. I don't know if I asked you a question on that, but anyway, just finishing off with hoarding. Looking at new treatments, so look at assigning different values, giving people perspective in terms of the worth of things they can't get rid of. To see them as not as valuable as they, these are people who will see something as having more value than almost anything, which is tremendous irrational thought associated with. I've been working with someone recently who just enjoys having things in her physical home. But it gives pleasure, it gives security, it's sort of an anti-anxiety agent. Those things generally don't have a lot of value. Some of them do, most do not. But there is something about that. And there was a period in her life where she did not have that, and that gave her a sense of insecurity, which is rather ironic, because many times people who do this end up financially having less, being less secure in that way. The decision making is not very rational, because what you're acquiring are often things that are not helping your life, objectively speaking, but subjectively, there's a great sense of, that this is somehow protecting you in some way. So just to mention that. Last one, call it C, that's the body dysmorphic disorder. And that is interesting because it keeps on going into different categories. They don't know where to place this in the DSM. Remember, the DSM is not very scientific. It's not really based on data. It's not data driven. It's what people have found. It's a high degree of subjectivity. Yeah.
I just wanted to ask real quick before we move on, for OCD, did you say CBT helps with that?
Yeah.
What about the hoarding?
Hoarding, you would do definitely trying to change thinking and behavior.
Okay.
Definitely with an emphasis on behavioral change.
Okay.
And, but, I think you'd want to go after the behavior as best you can.
Yes.
But that's important. But cognition too, because there's a lot of, there's a lot of irrationality to that. There's a woman I worked with once, I think there was some effectiveness with this. She was spending nearly as much, you'll have this, in fact, I have another person I'm working with, recently, maybe a year ago. And he was paying as much for storage as for rent. And you actually look at someone like that in their life, they often don't have any money, they're in financial distress. And if they had lose some of it, just doesn't make any sense. Because even if they were to get a bigger place, it might be able to replace the storage. The storage is everything. The storage takes over their life financially, unless you have a lot of needs. Actually, he's $1,000 a month for storage and $1,200 maybe for rent. Think about that over the course of decades. Someone's been doing it for a while. This is really the issue in their life, and behaviorally speaking, that has been so self-defeating. Those items have tremendous meaning, and maybe giving that person some perspective on that might be helpful. Changing that perspective. Anyway, finally, with regard to obsessive compulsive disorders, Body dysmorphic disorder, certainly, is this person obsessive?
Yeah.
Yes.
Yeah. Does this feel good?
No.
So it looks narcissistic. Does this person have a grandiose sense of self?
No.
A very devalued sense of self. But of course, if you go like this, what happens with your thoughts? If you're all like this, usually, that's not a great thing. Usually, yes, you're preoccupied with self. It could be narcissism, but oftentimes this leads to depression. If you're very internally, you're sort of, you want to go like that. You want to focus on things outside yourself, hobbies, interests, work. You want to be externally focused. That's actually one of the treatments for depression. You want to take those internal thoughts, particularly if you're obsessive. You want to go external with them. So with body dysmorphia, the preoccupation with some defect, but there's a real obsessive quality to it. And think about it just disproportionately, and that's really not that functional. Just there's not a lot of energy that's being invested in. And of course, a lot of biology too. It does seem that people like this are more prone to, thinking critically, self-critically, not in an analytic sense, but in terms of an obsessive sense. And one of the problems is with obsessions, medications don't work as well, and behavioral treatments, treatment generally, CBT doesn't work as well for the obsession, more so for the compulsion. If you want to change behavior, I think with body dysmorphia, it's a lot having to do with the thinking. To some degree, behavior, if you get a plastic surgery, things you get done, but a lot of it is that negative thinking, that person never feeling whole, and being very, very unpsychological,
And they just think like it's self-obsessed, but it's different than narcissism because it's like, it's never good enough. And they're never gonna be satisfied, so once they start focusing on like internal things, that's how they start to feel better about themselves. Like
well,
that's what
it's
fills
psychologically internal.
Yeah,
Right, rather than the
right,
external.
like, exactly, they work
Yeah.
on their mind and stuff like, I mean, I have so many friends, maybe I'm not like that. Maybe I can relate, I don't know,
Yeah.
but I mean,
Yeah.
I do, and that's what I tell my friends, I'm like, you have to stop yourself, like, four nose jobs, and it's never enough, and I'm like, you gotta start working on like, whatever's going on in your brain, because you'll never feel good about yourself, no matter how many nose jobs you get, until you start working on what's really going on.
Yeah, I mean, success is the best.
Yeah. So she said
Revenge,
therapy.
but it's also the best
We'll put
treatment.
the fourth nose job on hold.
I mean,
She got a new therapist.
Yeah.
Hopefully
Well,
that
usually
works.
therapy doesn't work that well because they want to talk about the nose job rather than something else, because the something else is very alien to them. The person
Mhm.
doesn't think necessarily in that way.
Right.
But it's very much based on that external, superficial, physical attribution or attributions.
So if talk therapy doesn't always work very well,
Yeah.
what else can be done?
Well, certainly exercise, meditation, getting work therapy, activity therapy, which is not a type of talk therapy, but just being very active and engaged, some people, let's say you're really super type A, we're talking about type A's before, and, a person like that needs to be busy and engaged. If they go on vacation and they start to think about themselves, they get depressed, and they get bored very easily. Your ADHD, characterize people as just one singular dimension, although that's the nature of this course. Being active and engaged is often helpful. In nursing homes, why do people get depressed? Not just because they're in a terrible position, although a lot of it is that, the lack of activity, the lack of engagement, the lack of things you're doing that feel like you have some outcomes that you're determined, rather than, that passivity and that lack of engagement is really unhealthy.
But then I think if they start exercising and stuff like that, then they get more self-obsessed. I think it's like move a muscle, change a thought.
Yeah,
That's
yeah.
exactly what it is. Like,
But it gives you
help
the
somebody
serotonin.
else, like when you're feeling bad about yourself, reach out and help somebody else to get outside of your head. It's that mentality.
Yes.
'Cause it's like once you start exercising, then you can get obsessed with that. There's like a very fine line.
Yeah, true, I guess, although the serotonin and dopamine, increases may help. Actually, the research is what's more effective, exercise or psychotherapy?
Exercise.
They're equal. Trick question. I'm not putting that in your gut.
Can you also do like things that aren't gonna burn that many calories, like yoga or, like,
Yeah.
there's
All
certain
the above, a
exercises- yeah.
multimodal treatment is often the best, so I'm not saying they should become obsessed with one thing.
Yeah.
But probably with activity, anything that gets them, engaged in something and gets them unfocused on themselves and what's missing from their life and their physicality is helpful. A busy person is often a happier person. Hobbies and interests, people who have them tend to do better. Just that alone, career or whatever, it's like, you don't want to just be ruminating. And the idea of rumination is, I guess free time, or at least in your head, you're thinking a lot. You want to diminish that. You want to go, anything that sort of lessens that is helpful. Okay, how are we doing? Okay, time. All right, let me give you guys about a 5 to 8 minute verbal quiz. Okay, most common anxiety disorder? Phobia. Okay.
What is it?
Phobia.
I thought you said another word.
Something about the Dodgers? Being obsessive.
Don't wear that head.
Don't worry, that it's
Triggering.
it's too much for me. It feels good. Some issues with triggered by that. The more social supports you have, the longer you live, the happier you are. Let's see. You have, you're hearing voices in your head. This is an example of a
Delusion.
hallucination. If those voices are telling you to do something, that's a hallucination of a, we talked about this, command type. I don't think I asked the question. Yeah, those voices, those are the ones that are concerning. They're, I don't know how rare, but they usually are more about a person hurting themselves than others with schizophrenia. But if those voices are telling you to do something, those are called command hallucinations or auditory hallucinations of the command type. Delusion, if you think you're God, that's a delusion or a hallucination?
Delusion.
That's a delusion. Most common assessment tool in terms of, as a therapist. The clinical interview, sometimes referred to as the diagnostic interview, the intake, or there are different terms that we use for that. You have a predisposition to schizophrenia. This is another name for this is you have a diathesis. I don't know if we said this, but if you have a predisposition to schizophrenia, diathesis. If you have a predisposition, you're testing my short-term memory. If you have a predisposition to schizophrenia and it doesn't fully activate, you may have this.
The threshold.
Schizotypal, right, where it's odd, eccentric. I don't think I asked this question because this is a lean word. Schizotypal. Don't worry about it, it's on your exam. And don't worry
I
about
only
it.
want what's
Don't
on
worry
the
about it
exam.
until 2 exams. Your third exam, you need to worry about this.
Let's revisit.
Schizotypal. We'll revisit. Wow. And the method of savings in psychology is the second time around, the easier and quicker and more efficient it is. So you'll have that working for you. You're this type of personality, really separate from the DSM. You're intense, you're overwhelmed, you set goals, your sense of urgency, and you're feeling a lot of stress. Type A. Someone asks you, do you ever get angry? I haven't been angry in 20 years.
Type B.
Type C. Type C, actually, yeah. Type C. You have, after being in a violent incident, 3 years later you start to have nightmares.
Delayed onset PTSD.
PTSD. You're in a car accident, within 10 days you start to have symptoms. Acute stress disorder. What are examples of a couple of symptoms of trauma? Nightmares.
Not being able to sleep.
Okay,
Being on edge.
feeling on edge.
Or numbness.
Numbness.
Hypervigilance.
Hypervigilance, feeling sort of, very hyper aroused or hyper alert to what may be happening. These are sort of classic examples. Trying intrusive thoughts that come into your head a lot, trying to avoid anything that reminds you of that stimulus or event. These are all symptoms of trauma. most effective treatment psychotherapeutically in treating depression? Cognitive or cognitive behavioral therapy, right, excellent. Your understanding, if you have a good understanding of self, in the clinical interview, this might be seen as having your understanding of self, or insight, yeah. The decisions you make in the world, that relates to judgment. If you have vague suicidal ideation, is this usually a cause of great concern? No. If there's specificity, yes. A plan. People are much more likely to be suicidal, or have ideation there, or homicidal ideation with regard to mental health treatment. Suicide, much more likely with suicidal. This is the treatment, the psychotherapeutic treatment for, actually two answers, for anxiety disorders. Behavioral or?
Exposure.
Or, which is an aspect of behavior, or cognitive behavior, behavioral or cognitive behavior. The most common modality of psychotherapy? Individual. Second most common modality of psychotherapy?
Family? Marital or couple?
Marital couple will be two, just fewer people. The more people, the more difficult it is to do. Let's see, deinstitutionalization, not on the board anymore, but really came into being largely in what period, what decade?
1970s.
1970. An easy question on this, just from say 1970s, because someone argued once that maybe one of the choices might have been 1950. So I'll tell you right
And
now.
that's the myth.
Yeah, the
Not
1950s.
See that, you already got it. You're already thinking, you're making those associations. Your brain is already working that way. You hear something and immediately, the med started in the 1950s, right? See that, you got that. That's a great sign. Most therapists report in terms of orientation being eclectic.
Say the question again?
Most therapists report in terms of orientation, somewhere up here, being eclectic.
Under treatment.
Yeah, right over here, eclectic. You're afraid of being in groups, and you avoid.
Social anxiety.
Social anxiety disorder. You thought you had a heart attack, it's not, and ruled out and everything, indicating that, and you're not limited in terms of going out in the world, so you're having
Panic
you have
attacks.
panic disorder without panic disorder without agoraphobia. Yeah, right. Panic disorder without agoraphobia. There are two types of personality tests. What are they? MMPI is an example of it.
That's objective, and the other one is projective.
Perfect. Oh, there you go. You got it. That's a tough question.
Really?
That's a very tough
Wait,
question.
which one is,
Yeah, okay. The personality, one objective is paper and pencil. There's a question, you answer it. Projective, Rorschach, you look, which is actually bad, but we have both objective and projective. But, you're asked to draw a person, a picture, a family, if you're a kid. Draw me a picture of your family. That's a projective test. They project from their head onto that piece of paper. Objective, there's actually a scoring system, a way to score and compare your responses to a larger group.
that's TAT?
That would be, no, but that's an example of an MMPI would be an objective test. I'm getting, you guys, this is too much in terms of, you don't even need to go this far. But if you got that, that's very good.
Objective.
Yeah, objective or projective. Yeah, that's probably a question I did not ask. You're a type C personality. Is this the DSM, by the way? Actually, it's separate, it's confusing in this class because it is separate from the DSM. It's not a DSM diagnosis. But if you're type C, do you express your feelings easily?
No.
What do you do with them? You internalize them. There's a particular type of feeling that's especially hard. Negative feeling. What type of negative feeling? for type C. Anger is very, very hard for people. You know, I guess, it's not really anger management. It's not even people who necessarily are acting out. It's often the idea of anger is often salient or difficult for people to acknowledge. Do type C. Type C is also more prone to stomach cancer. I think you guys, if you're getting these, you're good. This test is much easier than this.
It's the beginning stuff that I did.
Why didn't you put the test on the board?
Am I taking the test on the board?
I said, why didn't you put the test on the board?
I'll leave this up here, though, again, I left that, I had to erase one part, so. Go online, take a look, chapters 1 through 3, again, just the terms, you don't have to worry about the actual readings and knowing everything, just know the terms.
Just a question, I know this is not part of the exam or whatever, but for type C, you said they have, it's difficult to acknowledge their anger?
Yes.
But I've also always heard, you know, like anger is a secondary emotion. You know, like maybe you're hurt or you're embarrassed and it's easier to act angry than it is to make yourself vulnerable.
That's really good point.
Yeah.
By the way, what did Freud say about anger?
I don't know.
What did he say about depression? Anger turned inward.
Yes, interesting.
Right? So your points are terrific, yeah. You know, sort of the last story, the last quick story. I didn't have too much stories to tell you, Dodgers. The story is that I grew up with a guy who's now very, actually just found, I was online looking for people dying. No, this one was by accident. I found someone, and I don't, this guy is a very major, speaking of LA, major Hollywood composer and all sorts of movies. This guy's the dullest guy I've ever met in my life. There's nothing I remember about him other than the distinct. It's the same name. He looks the same. It's got to be the same person born the same year, but it's got to be him. But okay, so my thought is, so there are two people that live right near each other. They both went to music, very successful careers. One of them, though, not the Hollywood guy, the other guy, when he was a little kid, when he first met him, he cried all the time. I mean, into 5th, 6th grade. And he was constantly crying. He would have, meltdowns. He would have constant meltdowns. At some point, he was smart and must have realized that doesn't work. So he became very angry. Of course, I longed for the days when he was just melting down. He was nice. And then he became very angry. And by the way, he was much more functional. It was much more functional for him to be an angry young man than an emotional young man. So those emotions just got transferred into another. They were expressed differently because there was a lot going on there, and his music, I guess, was not enough. But he developed this real edge. You know, I'm not sure. I never had a conversation with him at that point because I actually nicknamed him Emotional Blank. He's laughing. I don't think he ever forgave me for that. He was looking for revenge, yeah. I got totally wrong, yeah. Just call him that, emotional, and see if he knows what it was. All right. Okay, so your exam, first thing, I'll give you guys about 35, 40 minutes to take it if you need more time. It's not a timed exam, not a big deal in terms of that. Don't worry about that. But we will actually get into new material after the exam. In terms of your getting back your exam, I gotta figure that maybe 1 or 2 people don't take it that same day. So I don't hand it back immediately, it'll be the week after. So you guys are taking it on what, the 1st of October? So you'll get it back the 8th. But if you want to know your grades within like 24 hours, 48 hours, I should have them graded. You can email me, or even next Monday, which would be 2 days before you get them back formally, I can give you a grade. We won't go over it, but I can give you a grade after class. So if you're feeling anxious about it, you can get your grade almost, not immediately, but within a day or 2 by email.
So can you email you, like, for example,
Yeah.
Thursday, Friday?
Yeah, Thursday or Friday I should have it. I just, why should you go around being obsessive? I know I was that way, so
What if everybody's finished with the exam and other people are not?
well, what we'll do there, you're not gonna get me obsessive about it.
I'm gonna get obsessive about it.
I would give those students time to finish up the exam. The only thing is I would get it done in material. Is that worrisome?
So basically, you can take the whole class for the exam.
If you need an hour to take the exam.
Right, but everybody else is
I
not,
definitely
that's a
agree
lot of
with that.
anxiety for that person.
Oh,
That's the
you're
last one
very
taking the
sympathetic.
test.
You're more empathic.
Cause I am
Right.
that person too,
You're
who's
that.
like, I take a long time.
If that's
so
the
when
case,
everybody's
I'll
done-
tell you what, if that's the case, we'll figure something out.
Well, and that-
I was actually thinking we'll take the chair.
at you.
Yeah,
I
right.
think it's gonna be the case. I think you're
Okay.
gonna be part of this. I think you'll be fine.
27 questions, not a
Well,
big
everybody
deal.
else is okay.
We'll figure it out.